Good evening, one and all. Good evening, respected mentor, Dr. Rajashekhar, sir. Sir, may I start presenting, sir?
Yeah, let's start. Right.
Yes. A 54 years aged female hailing from Villianur, who is a farmer by occupation of lower middle socioeconomic status, came with the chief complaints of fever for the past 2 months, cough with expectoration for the past 1 month, and shortness of breath for the past 1 month. Patient was apparently asymptomatic 2 months ago, following which she developed fever, which was continuous low-grade fever associated with evening rise of temperature with no chills or rigor, and patient said she used to take a single tablet of paracetamol for getting relief. Patient also complains of cough for the past 1 month, which is present throughout the day, associated with sputum production, which is mucoid in nature, scanty in amount, not foul smelling, not blood stained, with no postural or diurnal variation, and no aggravating or relieving factors. The cough is not associated with wheeze. The patient also complains of breathlessness for the past 1 month, which is insidious in onset, gradually progressive. Initially, patient had breathlessness on walking upstairs, but now has breathlessness even while walking a certain distance, that is grade 1 to grade 3 MMRC. It aggravates on lying on the left side and on coughing, but partially relieved on lying on the right side. Patient had also complaints of chest pain, which was acute in onset, left-sided, stabbing in nature, aggravated on inspiration and coughing, which was relieved on lying on the left side. But now there is no pain for the past 10 days, but the patient complains of tightness over the chest now. There is no history of paroxysmal nocturnal dyspnea or orthopnea, no history of halitosis. There's history of loss of weight of about 7 kgs in the past 2 months, and there is history of reduced appetite. There's no history of swelling in the legs, syncope, puffiness of face, or reduced urine output. No history of skin rashes or joint pain. There's no history of change in voice or difficulty in swallowing. Past history, there are no similar illnesses in the past. The patient is not a known case of diabetes, hypertension, bronchial asthma, collagen vascular disorders, malignancies. There is no history of contact with the patient of TB. There is no history of any previous surgeries. Personal history, patient consumes a mixed diet. She has a normal sleep-wake cycle and normal bowel and bladder movements. There is no history of any alcohol intake or pan chewing or substance abuse. She works as a 100 days worker in the paddy fields. Family history, there is no history of similar illness in the family. Her husband is also a farmer and for past 30 years smokes at least 5 BDs per day. There is no history of TB or any malignancies in the family. Summary, a 54 years old female came with complaints of fever for past 2 months, which was continuous and low grade with evening rise of temperature and with no chills and rigors. She complains of cough with expectoration with scanty sputum, not bloodstained, with no postural or diurnal variation, and cough is present throughout the day and not associated with wheeze. She also complains of progressive breathlessness, which aggravates on coughing and lying on the left side and partially relieved on lying on the right side. She has unintentional significant weight loss up to 7 kgs in the past 2 months and reduced appetite. All the points indicate a chronic respiratory disease, probably which is pleural in origin, and I would like to examine the respiratory system, sir.
You can go back to the first slide.
Yes, sir.
So, what is your final inference based on the history?
So, based on the history, I suspect TB, sir, because the patient has had complaints
No,
of.
I'm not talking about the etiology directly.
Okay, sir.
What pathology you are suspecting?
It could be a pleural of effusion, sir.
Okay, only one diagnosis based on this history.
Apart from that, there could be a consolidation, sir.
Why do you think so? So you are sitting in a
it could be a
occupational
lung
fever for 2 months,
yes,
cough with since 1 month, shortness of breath since 1 month, and only one
yes.
and only one diagnosis, that is pleural effusion. Is it so?
No, sir. There could be any interstitial lung disease, sir.
Interstitial lung disease. Okay.
Yes,
next, any other?
There could also be
Okay, your first probable diagnosis is pleural origin, right? You told me that is
Yes,
a
sir.
pleural origin. So what
Yes, sir.
pathology? If
Effusion,
it's an
sir.
effusion or it is a pleural malignancy or pleuritis, what you're suspecting?
Sorry, sir.
Your first inference was pleural origin of a pathology, right?
Yes, sir.
So what pathology of pleura you're suspecting in your patient, whether effusion or whether some empyema or hemothorax, pneumothorax, all these are pleural origin, right?
Yes, sir.
So
So
what pleural disease you're suspecting?
given the histories of for past 2 months, we
Yeah.
can rule out pneumothorax, sir, because pneumothorax
Okay.
is of acute onset. Apart from
Okay.
that, we can think of pleural effusion or any pleural malignancies like mesothelioma.
Okay. No, just I want you to tell the differential diagnosis 1, 2, 3,
Yes,
4,
sir.
5. What is your first one you want to keep?
First one, I would like to go with pleural effusion, sir. Secondly,
First differential diagnosis you want to keep in this presentation is pleural effusion.
yes, sir.
So what are the points in favor of pleural effusion?
The patient has had pleuritic type of chest pain, sir, 10 days ago,
Okay.
following
Okay.
which it has resolved and there is tightness in one side of the chest, sir.
Okay.
Apart from that,
Why do you say it is pleuritic type of chest pain?
so because it is stabbing in nature, and it is aggravated on deep inspiration or coughing or sneezing, sir, and it is relieved
Okay.
on lying on the same side of the pathology, sir.
Okay. Location. What is the location of the pain?
Left side, sir.
Left side where?
Uh,
It is in the
patient
axillary region or it is in the anterior chest, in the posterior chest?
in the anterior chest, sir.
Okay. The patient complains of anterior type of chest pain, right?
Yes, sir.
So you didn't mention the location in your history, or you mentioned?
No, sir.
Okay, just remember to mention the location of pain. That is very, very important, right?
Yes, sir.
Okay, you have mentioned the character, the onset, etc., but you have not mentioned the site of the pain. So the pleuritic type of chest pain to be typical, where it is usually located?
Uh,
Whether it is in the anterior side or in the axilla or in the posterior side?
is usually in the axilla, sir.
It is in the lower axilla or preferably on the posterior side, below the scapula. That is where the patient usually complains of the typical pleuritic type of chest pain. Okay.
Yes,
So in
yes.
your case, this is one atypical feature which is going like not in favor of pleuritic, but it directly cannot rule out the pleuritic type of chest pain. So your first differential diagnosis was pleural effusion. You are suspecting pleural effusion first because the patient has what is called, that is pleuritic type of chest pain, that is point in favor of pleural effusion. What are the points, other points which are in favor of your first differential diagnosis?
So there is gradually progressive breathlessness, sir,
Okay.
which is aggravated on lying on the left side, whereas on lying on the uh, normal side, it is relieved, sir.
Why it is so?
So because when in cases of unilateral lung diseases, if the
Okay.
patient lies on the normal side, there will be increased perfusion and it will relieve the dyspnea, sir.
Okay. So it can occur in any unilateral lung disease, right?
Yes, sir.
And why do you say it is an effusion? What is
I
this
don't know.
type of dyspnea is called?
This is called trepopnea, sir.
Trepopnea, right?
Yes, sir.
Terminology given for this particular type of the positional change of dyspnea is called as trepopnea.
Yes, sir.
So this suggests what?
So this
The
suggests
unilateral
that
lung
there is
disease, you told me, right?
yes, sir. Yes.
Any other causes for this trepopnea other than unilateral lung disease?
Other than this, it can also occur in cardiac causes like congestive cardiac failures.
Okay.
And
So
um,
Okay, I just want you to write down the questions. Okay.
Yes.
If at all this is applicable for all the students, okay, you can write down the questions. I will be telling the answers also,
Yes.
but it is better for you guys to go and search for the answer, because the human brain remembers in a much better way if you actually look for the answers in the textbooks rather than somebody telling the answers.
Yes.
Okay, if you yourself look for the answers from some textbook searching, etc., if you do that, then you will never forget those answers.
Yes.
Okay. So this basic pathophysiology of this Trepopnea, if you read actually, there has been a lot of controversies actually, depending on what side they should lie, what side they are relieved, what side they are aggravated.
Yes.
Okay. So please understand, suppose if there is a right-sided lung pathology, okay?
Okay.
Understand, if there is a right-sided lung pathology, what happens if this patient lies on right side lower down? That is, he is lying on his right-sided chest in the lower side and left-sided chest is on the above.
Okay.
Okay. What is happening is this abnormal side is lower.
Yes, sir.
Okay. So this abnormal side is lower. So the perfusion is going to increase because of gravity.
Yes, sir.
But ventilation is not going to occur because the lung is pathology. For example, if the alveoli is filled with the fluid, alveoli is filled with the pus, if the interstitium is damaged, okay?
Yes, sir.
So there is a ventilation perfusion mismatch which gets increases on the affected side being down.
Okay, sir.
In other lung pathologies, okay? The
Yes,
only lung pathology which gets relieved on sleeping on the side of the pathology is the pleural effusion.
Okay, sir.
Am I clear?
Yes, sir.
Okay, all the other pathologies of the lung, for example, if there is a major airway bronchus on the single side, if there is a gross pneumonia, or if there is a gross, what you call, the airway, major airway obstruction, this particular condition is going to increase on lying on the side.
Okay, sir.
Affected side, okay? So
Yes,
here, your patient is getting relieved on the right side.
Yes, sir.
Okay, if there is only one history available, that for example, if there is a dyspnea which is getting relieved on the right side, then what you should think is either right-sided lung pathology or left-sided pleural effusion.
Yes, sir.
Am I clear?
Yes, sir.
So in your patient, since your patient also has got a left-sided pleuritic type of chest pain,
Yes, sir.
and a dyspnea which was relieving on lying on the right side.
Yes, sir.
Yes, this is a very typical history of the pleural effusion.
Okay, sir.
Okay.
Yes, sir.
Okay. Again, in case of congestive heart cardiac failure, there are many what you call the pathologic mechanisms which can cause Trepopnea. One of the mechanism is also the coexistent pleural effusion in those patients.
Okay, sir.
Okay. Congestive cardiac failure are usually having the pleural effusion invariably bilateral, preferably right more than left.
Okay.
Okay.
Yes.
So they one of the reason for cardiac failure patients to develop Trepopnea is the pleural effusion. Okay.
Yes. Yes, sir.
Okay. So then, what are the other points in favor of the pleural effusion in your patient? One, there is pleuritic type of chest pain, you told me, and then there was a gradual onset increasing breathlessness.
Yes, sir.
And then there was a significant history of Trepopnea.
Yes, sir.
Which was correlating with your pleuritic type of chest pain. That's a good history indeed. Okay.
Yes, sir.
Okay, tell me, what are the points against pleural effusion in your history? Is anything going against pleural effusion in your patient?
So presence of cough with scanty sputum.
Okay, that is against what's called pleural effusion.
Yes, sir, because sputum production usually occurs in cases of parenchymal involvement. Sir.
Okay, and other causes of the sputum production other than parenchymal involvement?
Airways, if airways are involved, like asthma or COPD.
Any airway stimulus, like due to goblet cell hyperplasia, right?
Yes, sir.
So if there is an significant amount of the expectoration. Either you are suspecting the parenchymal involvement or the airway involvement. Okay.
Yes, sir. Yes, sir.
So cough is usually not a feature of the pleural effusion.
Yes.
If at all it is there, it will be dry. Okay. How will you explain cough
Yes,
in
sir.
the patient pleural effusion? Are cough's receptors situated on the parietal pleura? Am I audible, Akash?
Yes, yes, sir. Yes.
Yeah.
Uh,
Are there any cough receptors situated on the parietal or visceral pleura?
on the parietal pleura, cough receptors are present, sir. And
No. It is pain receptor. They are not cough receptors.
okay, sir.
So how do you explain cough in case of pleural effusion? What happens to the underlying lung when there is pleural effusion?
So, the underlying lung goes for compression atelectasis. So it will be compressed.
Right. So this is the atelectasis, okay, which is causing cough in the patient. Okay.
Okay. Yes.
So cough is usually less significant in case of the pleural diseases per se.
Yes.
If at all you are suspecting cough in case of pleural disease, then it is usually due to underlying atelectasis. Okay.
Okay.
Okay. Then any other diagnosis you can think of in your patient? There is cough.
It could be a
dyspnea.
malignancy, sir.
Okay, it can be a malignancy. Then earlier you told me the interstitial lung disease.
Yes, sir.
Which one you want to keep as a second thing?
Since the patient is a farmer by occupation and belongs to the lower socioeconomic status, I would like to keep interstitial lung disease as the second option, sir. And lastly, for malignancy.
How the socioeconomic status is related to the what you call possibility of this interstitial lung disease?
So usually workers in the asbestos industry or the cotton industry or the coal industry, they are more exposed to the lung irritants such as coal or the asbestos, leading to interstitial lung disease like asbestosis or pneumonias.
Agreed. Does our patient have the history which is suggestive of the asbestosis or something like exposure?
No, sir.
So then why do you want to keep ILD as a second differential diagnosis?
But sir, there is also presence of cough with scanty sputum, so therefore I thought of that.
Okay.
Then since the patient is towards the above 50 years of age and there is history of significant loss of weight and appetite, I would also like to think of malignancies, internal malignancies.
Okay, internal malignancy. No. Okay, what internal malignancy? Okay,
mainly
lung malignancy.
bronchogenic carcinoma. Yes.
Okay, mainly a bronchogenic carcinoma. Okay.
Yes.
So any other malignancies, okay, which might present with the predominant respiratory symptoms, but they are not of respiratory origin?
So since my patient is a female, it could be a breast or a thyroid carcinoma, which could have metastasized to the lungs.
Yeah, that's very good. And you should ask that history in particular when you are ruling out the negative history. Okay, history of any lump in the breast.
Okay, sir.
Okay, that becomes very, very important. That history is missing in your patient. Okay.
Yes. Yes, sir. Okay, sir.
So you should add that history.
Yes, sir.
Okay. So what are the points in favor of malignancy in your patient? So, okay, for the purpose, then we will not consider the breast malignancy. Okay, as the possibility here. We will consider that you have asked that history and there is no history of any lump in the breast. Okay.
Okay.
And similarly, it goes with the history of any swellings. Okay, multiple swellings in the neck region or in the axillary region. That history should also be asked. Okay. Since you are keeping malignancy as your second differential diagnosis, those negative history should also be considered. Okay. For example, if you ask the negative history, then you have come to the end of the history, your second differential diagnosis become malignancy, then you can again go back to the patient, then and you can ask the histories, all these which are missing.
Okay.
Okay.
Yes, sir.
So, we're considering that the patient may not have any breast lump. What are the points in favor of malignancy?
Sir, there is the patient is a elderly female, about 54 to 55 years, and there is
Okay.
history of significant weight loss, sir, in the past 2 months.
Okay.
And there is
Okay.
loss of appetite also, sir.
Okay. So what is this significant weight loss means?
So significant weight loss is defined as a 5% weight loss in the past 3 months or a 10% of the weight loss in the past 6 months. Sir.
Okay. Any
And
absolute value? Any absolute value rather than the percentage?
I don't know, sir.
Okay. Either it is more than 5% loss or loss of more than 10 pounds.
Okay, sir.
Or more than 4.5 kgs.
Okay, sir.
Okay, in last 6 to 12 months. It's either of three. Okay.
Yes, sir.
You should know all the definitions.
Okay, sir.
So what does this history suggest you of?
So
what do you, how do you interfere this, infer this significant weight loss in your patient?
So the patient has also had a history of low-grade continuous type of fever, which is associated with evening rise of temperature, sir. So in patient with fevers of such long duration, there will be increased amount of interleukins in their circulation, sir, which will cause a reduced appetite and loss of weight, sir.
No, I'm just asking the causes of this unintentional weight loss.
Yes, sir. It could be as of infective causes, it could be tuberculosis or HIV, sir.
Any other infections? Other than tuberculosis and HIV?
I don't know, sir.
Okay. Any chronic parasitic infestations?
Okay, sir.
Okay. Fungal infections, even though.
Fungal infection. Okay, sir.
Okay. So
yes.
These should also be suspected when there is a significant weight loss. Okay.
Okay, sir. Yes,
especially in tropical countries like India, the parasitic infections are the considerable causes here. Okay.
Yes.
So everybody tends to remember only HIV and tuberculosis, but there are other diseases also. Okay.
Yes.
Other than any infections, what do you think as the cause?
So there could be metabolic disturbances like thyrotoxicosis or uncontrolled diabetes. Sir.
Yeah. Right.
And thirdly, malignancy.
Any other metabolic things, or endocrine things, of other than thyrotoxicosis?
So uncontrolled diabetes can cause significant weight loss.
Other than thyrotoxicosis and diabetes. Other than those two? Adrenal insufficiency. Okay. Chronic adrenal insufficiency can also cause a significant weight loss. Okay.
Okay.
So then, what is the first thing that should come in mind whenever there is a loss of appetite? Loss of weight, other than infection and the metabolic things. First thing in an old age patient.
So malignancy should be.
Yeah, malignancy. What are the malignancies which are usually notorious in causing significant weight loss?
Sir, bronchogenic carcinoma.
Yeah, lung malignancy, right?
Lung malignancies. Gastric malignancies like
carcinoma. Right, very good. Then proximal to gastric, what is there?
Esophageal cancers.
Yeah, very good. Next other than GIT and lung? Hematological malignancies. Okay.
Hematological. Yes.
This leukemia, lymphomas. Okay.
Yes.
These are very important in causing significant weight loss. So this becomes very, very important here. So this is the point which takes you for the second differential diagnosis. Okay. So there's a malignancy as the cause. Any other cause? Any other differential diagnosis for cough and dyspnea since 1 month?
Cough and dyspnea.
Any other interstitial lung disease other than what you call the asbestosis. Asbestosis was a more of an occupational lung disease rather than an interstitial lung disease, although interstitial is definitely involved.
Okay.
Okay,
Yes,
whenever we use the terminology of the interstitial lung disease, there are separate set of disorders, isn't it?
okay, sir. Yes, sir.
Asbestosis was a usually occupational kind of disorder.
Okay, sir.
So any other interstitial lung diseases?
So it could be a idiopathic pulmonary fibrosis.
Yeah, that's good. Is the epidemiology favors the development of IPF in this patient? The age, the sex, and the past history or the presentations, anything is in favor? What is the usual age of onset of the IPF?
Mainly in the elderly, it's about 50.
Yeah, okay. It is usually a postmenopausal woman or men. Okay.
Yes.
And I forgot to ask one thing. Was there any history in favor of malignancy in your patient other than this history of presenting illness?
No, sir. No.
No. You told me her husband is a smoker, right?
Yes, sir. There's passive smoking.
Yeah. Is passive smoking a risk for development of malignancy?
Yes, sir. That could be a risk. Yes, sir.
Yeah. That is a point in favor, right?
Yes, sir.
Yeah. That is also called as second-hand smoking.
Yes, sir.
Isn't it?
Okay.
Yeah.
Yes, sir.
Okay. So any other diagnosis you want to keep in your patient? You're an intern, right?
I don't know.
You're an intern, right? You're a final year student or intern?
So I just finished my final year. I'm going to intermediate.
That's good. Okay, so that's why I'm asking you directly the differential diagnosis. I'm not going for what are the causes of fever, what are the causes of dyspnea, all these things. Okay, you're now a step ahead.
Yes.
Isn't it?
Yes.
Yeah. So any other differential diagnosis other than effusion, malignancy, interstitial lung disease? You should have a broad mind, isn't it?
Sir?
So tell me. No, you should have a very broad mind whenever a patient comes to you. You should have a broad mind. What else can it be? What else can it be? That is what makes you a special doctor. Okay.
Yes.
What else it can be?
It could be.
If at all you are suspecting any, I will give you the right approach. Okay.
Yes.
When you are suspecting any respiratory disease involvement,
yes,
or any chest-related involvement, I think you know about 90% of the things. Either it is arising from the airway, either it is arising from the parenchyma,
yes,
or it is arising from the interstitium, or it is arising from the pulmonary vasculature, or it is arising from the pleura, or is it arising from the other structures which are situated in the chest, that is either esophagus or pericardium, heart, or esophagus or mediastinum. Okay.
Yes, sir.
And each site of involvement usually presents in a unique way. Although there is some overlap, they have got a unique way. So, and each conditions and each particular location have some acute disorders, some subacute disorders, and some chronic disorders. Okay.
Yes, sir. Yes, sir.
So you involve the pleura, you involve some malignant development, you involve the interstitium. Okay. Any alveolar parenchymal disease presenting in a similar way, where there is fever, low grade, cough, some amount of dyspnea on exertion, which is gradually progressive, although there may not be any trepopnea, any alveolar things or parenchymal things.
Bronchial asthma, sir.
Bronchial asthma. Okay, what are the points against bronchial asthma in your patient? What is the usually significant history? Is it a continuous process or an intermittent process?
So it is intermittent, sir. And
okay,
it is usually associated
an intermittent process. Usually have an exacerbations.
Yes, sir.
And those exacerbations usually have a triggering events. Either there is a seasonal change,
Yes.
or if it is an exposure to the allergen, okay, or some food related exacerbations. So it depends on the individual susceptibility. So this bronchial asthma is usually an intermittent process rather than the gradually progressive process. Okay.
Yes.
So any other disease? Can it be pneumonia? Somebody has given in the chat box a clue, a pneumonia. Can it be pneumonia? What is the usual presentation of pneumonia? Pneumonia is an acute thing, or a subacute thing, or a chronic thing?
Pneumonia is usually acute in
Hello?
Am I audible, sir?
Yeah, you're audible. Am I audible?
Yes, sir. Sorry, sir.
Yeah. So can it be pneumonia?
Dr.
You can share
Aakash,
the
you
screen.
can share your screen now.
Yes.
Yeah. Can it be pneumonia, Akash?
Pneumonia, if it is in the resolution stage, it could be pneumonia, sir.
If it is the resolution stage. No, if the resolution stage is there, then why the dyspnea is progressing? That is against pneumonia, right?
Yes, sir.
Resolution pneumonia. What is unresolved pneumonia?
There could be a delayed resolution because of any subpulmonic effusion, sir.
Right, good.
Uh,
Then how do you rule out an unresolved pneumonia, whether the patient has received adequate treatment or not for the pneumonia?
I don't know, sir.
Have you asked that history? For these complaints, did she show to any doctors in the local authority, or did she receive any kind of treatments?
No, sir. She has not gone to any other doctor. She has directly come to our hospital. She was a camp patient, sir.
Okay, that's well and good. Then it's definitely not pneumonia, right?
Yes, sir.
That definitely it is not unresolved pneumonia. If at all you want to label the pneumonia as unresolved, there has to be a history of receival of treatment.
Yes, sir.
And which has not responded.
Yes, sir.
That is not available in your patient. So I think in some section you should mention that history, that for these complaints, patient haven't took any treatment apart from that single tablet of paracetamol which you used to take.
Yes.
Okay.
Yes.
So that becomes that can rule out some history. Okay.
Okay.
What is organizing pneumonia?
Organizing pneumonia, it is in the second stage, sir, wherein there will be increased production of the inflammatory exudates, and there will be fibrinosis.
No. You are staging you are just telling me the stages of the pneumonia development. I'm not asking you that. What is the typical terminology called COP, that is cryptogenic organizing pneumonia? Have you heard of this condition?
No, sir.
Okay, earlier it was called as BOOP, that is bronchiolitis obliterans organizing pneumonia.
Okay, sir.
Okay, this cryptogenic organizing pneumonia, it is usually the low grade pneumonia which is occurring in the patient. It is usually not infective. Okay.
Yes,
majority of the people thinks that is an infection, so they treat it with a routine antibiotics, but it is not an infective cause because it typically presents as pneumonia in case of the radiological presentation. If you see, it just looks like a lobar pneumonia.
Okay.
But here the patient will not respond to the routine antibiotics because it is usually secondary to either some collagen vascular disease, okay, or any chronic low-grade inflammation. Okay.
Yes, sir. Yes, sir.
Where you might add the steroid to relieve the patient of this pneumonia. So that can be the differential diagnosis you can keep in your patient.
Yes.
Although that will definitely not explain the Trepopnea and the typical pleural type of chest pain.
Yes, sir. Yes.
Okay.
Yes, sir.
Did your patient had hemoptysis?
No, sir. There was no history of hemoptysis.
So you should mention that history.
So I have mentioned there is no bloodstain coughs.
Okay, mentioned, right? That's good.
Yes, sir.
So if at all there was a hemoptysis in this patient, how would this would have taken you to the diagnosis or the differential diagnosis?
So it would have pointed more towards the malignancy, sir.
Okay, that's good. That's good.
And
okay.
yes, sir.
So what is hemoptysis?
So it is a coughing of blood, sir, which is preceded by episode of cough, sir.
Okay. How do you differentiate it from the hematemesis?
In case of hematemesis, it is vomiting of blood, sir, whereas hemoptysis is coughing up of blood. Hemoptysis is usually alkaline in pH, whereas hematemesis is acidic.
No, just tell me clinical things, okay, not
yes,
the laboratory things. No.
Okay. Hematemesis is usually brown or black in color because of addition of acids. So it causes acid hematine production, whereas hemoptysis will be in frank red, sir.
Okay, that's good. Okay, how will you differentiate if the patient has swallowed his blood-stained sputum?
Yes, sir.
Then he has vomited that sputum. How will you differentiate that? Is it possible?
So usually children swallow their sputum. Sir.
Yeah. And some adults, they might swallow.
Okay.
Okay, although it is very common in children,
yes,
okay, some adults might swallow. Okay.
Yes, sir.
So how will you differentiate that?
I don't know, sir.
Okay, that's a question. Okay.
Okay, sir.
You can write down, you can answer that question.
Yes, sir.
Okay. So next, coming to your history of chest pain in your patient, you're telling me that for the past 10 days, there is no chest pain.
Yes, sir.
Is the disease has gone?
No, sir. It could be due to a progressive effusion, sir, which separates both the parietal and the visceral pleura,
right?
Which has stopped the pain, sir.
Okay. And this particular thing can occur even during the resolution of this effusion, if at all it is existing in your patient. Okay.
Okay. Yes, sir.
So whatever the type of this pleuritic type of chest pain is again going to come at the end of this disappearance of the fluid in the pleural space.
Yes.
Okay.
Okay.
Sometimes during the resolution time, the patient might complain of chest pain, which was similar to the initial chest pain which you used to get. Okay.
Okay. Yes, sir.
So this you should explain to the patient whenever you have a pleural effusion.
Okay, sir. Yes, sir.
So your first differential diagnosis is pleural effusion because majority of the points goes in favor of pleural effusion. Although one thing that is going against is predominant cough, which is your second symptom.
Yes, sir.
Then with some amount of the mucus production. Then the second differential diagnosis either malignancy. The third differential diagnosis is rarely an interstitial lung disease, although dyspnea with the preferential one-sided predominance will not go in favor of the interstitial lung disease.
Okay.
Okay. Then any other thing other than the pulmonary or a pleural disease which you can suspect in your patient in this particular history? As I told you in the approach, it can be from any other structure or site arising in the chest or thoracic cavity.
Since the patient has a long history of fever, low-grade fever, it would be infective endocarditis.
Infective endocarditis. Okay. What is the point in favor or in against of infective endocarditis in your patient?
In favor, it is a low-grade continuous type of fever, sir. So
what type of endocarditis usually have this kind of low-grade fever?
A bacterial endocarditis.
Acute, subacute, or a chronic?
Subacute bacterial endocarditis.
Subacute. You should specifically mention that. Okay.
Okay.
Okay, so what are the points against the endocarditis? Fever is in support of subacute endocarditis.
Yes.
What is the point against?
There's presence of cough with expectoration, sir.
Yeah.
And there's no history of yellowish discoloration, sir, because usually it produces jaundice. Sir.
Okay, then this dyspnea lying on one side, which is aggravated on the left side, relieved on the right side.
Okay, sir.
You cannot explain this with what you call infected endocarditis, right?
Yes.
See, everything is there in your history. You just know how to explain.
Okay, sir.
Okay, it is all about you whether to know whether you know the things or not.
Okay, sir.
Okay, so
Yes, sir.
any other things, any other than endocarditis?
That's all. Sir.
Okay, leave aside heart, any cardiac condition. Forget about cardiac conditions.
Okay. Sir.
And respiratory conditions. Any other thing?
I don't know.
Any mediastinal involvement?
No, sir.
No. Can it be sarcoidosis?
Yes, sir. Sarcoidosis usually presents with cough and chest pains and breathlessness also.
Yeah. So you know things, okay? You just know how to reproduce them.
Okay. Sir.
Okay. So what are the points? What should have been the other histories which should be there to know or to suspect sarcoidosis in your patient?
Whether there is any history of joint pain or skin rashes.
Yeah. Okay, that is not available in this patient. Okay.
Yes, sir.
So any other thing? Can it be lymphoma with a mediastinal lymphadenopathy?
Yes, sir.
It can be, right?
Yes, sir. Can be.
Yeah. Then it may be compressing one major bronchus.
Yes, sir.
Which can explain the trepopnea in the patient.
Okay, sir.
Am I clear?
Yes, sir.
Okay, and this patient can also have this pleuritic type of chest pain due to some amount of effusion. They might coexist.
Okay, sir.
Okay.
Yes, sir.
So many differential diagnoses you can have with this history. Okay, it's not just a pleural effusion. Huh?
Okay, sir.
And can it be chronic mediastinitis? Have you heard of this condition?
No, chronic mediastinitis I haven't heard, sir.
Okay, chronic mediastinitis can be the condition. It is similar to your fibrosing conditions, which can be associated with some IgG4 related diseases or some drugs. Okay, like methotrexate, the amiodarone, etc. Okay,
yes,
although very rare, but they can cause any unexplained cough in the patient, low-grade fever causing inflammation. Okay.
Yes, sir.
And some amount of dyspnea due to the fibrosis of the surrounding bronchus.
Okay. Sir.
Okay, then I think you need to come back to the first chief complaint, that is fever.
Yes, sir.
Okay, explain me this fever. Till now, I haven't asked you about the fever. So, considering only cough and the dyspnea with the pleuritic type of chest pain, we have kept so many differential diagnoses. Okay.
Yes,
it can be pleural effusion, it can be malignancy, it can be the mediastinal lymphadenopathy, it can be interstitial lung disease, it can be chronic organizing pneumonia, it can be anything. So what this particular history of fever is going to offer you extra?
So since the
Why
fever,
do you say it is a continuous fever?
So because there are no, the fever does not touch the baseline, sir, and it is in a steady state, sir. It is gradually progressing, and however, it is low grade, sir.
Okay.
And it is also associated with the evening rise of temperature, sir.
What does that mean? Evening rise of temperature?
Since there is a decrease in the level of cortisol in the evening, sir, the increased pyrogens will cause a increase in the temperature. Along with that, there is also a circadian rhythm of the temperature, which usually increases during the evenings.
Oh, that should be the first reason. Okay.
Yes, sir.
whenever somebody asks you the evening rise of temperature, just don't go to the steroid and don't blame the steroid directly. First, it is a normal phenomena. Normal phenomena, although it's just because of steroids only, but
Yes,
it is better to explain as the normal circadian rhythm. What is a normal circadian rhythm or diurnal variation of temperature? And it is
usually
going to be more, whether it is in the evening time or in the morning time.
in the morning time it will be less, sir, whereas towards the
Okay.
evening it will be increasing, sir.
So this is normal temperature.
Yes, sir.
Okay, so in normal person also there is some amount of evening rise of temperature. Okay, in
Yes,
your
sir.
patient also there is evening rise of temperature,
Yes, sir.
and it is low grade,
Yes, sir.
and it is not associated with chills and rigors. So what does
Yes.
it mean? What is it going to tell you?
It is not as it means that the degree of fever, it is not very high. That is, the intensity of
Okay.
fever is not very high, because in
Okay.
high grade fever usually there is a resetting of the temperature in the hypothalamus, sir. So
No.
to
There is
increase.
reset of temperature in all causes of fever.
Okay, sir.
Okay.
Yes, sir.
In continuous fever, low grade fever, there is no reset of temperature. There is a
There will
reset
be,
of temperature. Okay.
yes, sir.
And
Yes,
there
sir.
is no reset of temperature, and you see the patient is having the higher temperature, then it is called
Hyperthermia, sir.
it is hyperthermia, right? So
Yes,
in
sir.
all causes of fever, there is a hypothalamic reset.
Yes, sir.
Okay, it is just a sudden drop or rise in the temperature. Okay,
Yes, sir.
which causes this chills and rigors.
Okay, sir.
Okay.
Yes, sir.
So can you tell me any cause of fever where there is a reversal of this diurnal variation? There is a particular terminology that is being given to that pattern of fever. Do you know?
I can't recollect, sir.
Okay, I don't think it is mentioned in textbooks also. This is called typhus inversus.
Okay, sir.
Okay.
Yes, sir.
So this typhus inversus means this is a reversal of diurnal pattern. Okay, where the temperature is high in the morning and low in the evening.
Okay, sir.
Okay, so what are the conditions which causes typhus inversus? Do you know?
No, sir.
Okay, one cause is disseminated tuberculosis.
Okay, sir.
Okay, whenever there is a disseminated, like it is a miliary, extrapulmonary with meningitis, okay, or
Yes,
with
sir.
the abdominal tuberculosis, all this disseminated tuberculosis can have this typhus inversus. Other conditions are some abscess in the deep-seated organs like hepatic abscess, liver abscess, the splenic abscesses.
Okay, sir.
Okay, and another very characteristic cause is this PAN, PAN. Do you know what is this?
Sorry, sir.
PAN, PAN.
Polyarthritis nodosa.
Yeah, polyarthritis nodosa is one cause for this typhus inversus. Okay.
Okay, sir.
So this is like a bonus question. So you can read about the typhus inversus.
Okay, sir.
This is, I think, it is not mentioned in any clinical textbooks, but it is been there in the literature. Okay, it is one of the pattern which can help you the differential diagnosis. Okay.
Okay, sir.
So another cause is, what does this low grade fever with evening rise of temperature suggest? What you are suspecting in your patient?
It could probably be a tuberculosis, sir.
Okay, right. That should come as a first differential diagnosis, being in India as a
Yes.
what you call evening low grade rise in temperature. Okay.
Yes, sir.
Then any other cause? Can there be a high grade fever in tuberculosis?
In case of miliary TB, sir.
Yeah, that's good. Another one? Tubercular meningitis.
Okay, sir.
Okay, it is not like must have. It can be there. Okay.
Okay, sir.
Biliary, and it can in meningeal tuberculosis, the pattern might vary from the usual pattern. Okay.
Okay, sir.
Is fever must for tuberculosis?
No, sir.
No.
But usually, yes.
Yeah, fever may not be there. Okay, tell me one condition where fever should be there to consider diagnosis.
I didn't get the question, sir.
Tell me one condition or one infection. Like there are many infections who might
Yes, sir.
present
Yes, sir.
without any fever, like for some diabetics, for some old age people, some kidney disease patient who are not able to mount the immune response, the
Okay, sir.
pyrogenic response to develop fever. But there is
Okay,
one
sir.
infection which cannot occur without showing the fever.
Um,
It is infective endocarditis. Okay.
okay, sir. Yes.
Especially acute infective endocarditis. In fact, the disappearance of fever in 48 hours is a ruling out criteria for infective endocarditis. Okay.
Okay. Yes, sir.
Fever
Okay,
cannot disappear in just 48 hours. Okay.
okay, sir.
There are all other infections, even your pneumonia, UTI, they can also be there without any fever. They can have some atypical manifestations, like some just a malaise, some altered sensorium in old patients. Okay. A pain
Okay, sir.
abdomen, just loss of appetite. All these can be there, even though fever may not be there. But there is one infection, that is infective endocarditis, which usually shows fever, or which should show fever. Okay.
Okay, sir.
So without fever, you cannot have infective endocarditis as a differential diagnosis in your patient, especially the acute infective endocarditis. There are some things, especially like Q fever, the Coxiella burnetii causing infective endocarditis can have this low-grade fever, but acute and majority of subacute usually have fever as a predominant symptom. Okay.
Okay, sir.
Tell me other causes of the other patterns of fever for the sake of completion.
Intermittent fever, sir, and remittent fever.
Yeah. What is remittent?
Remittent is less than the fluctuation is less than 1 degree Fahrenheit, and it touches the
Okay.
baseline, sir.
Are you sure?
So it does not touch the baseline, sir.
Sure.
Yes, sir.
Okay. What is continuous? Tell me.
There's
Okay,
no
there is you used to get a lot of confusions when you read this. You think that you're understood, but when examiner actually throws the question, there is some amount of usual confusion. I have seen in many students. Okay,
yes,
especially the undergraduates. You should know two things to know the pattern. One is what is the variation, whether
yes,
it is more than Fahrenheit or less than Fahrenheit, and whether it is touching the baseline or not.
okay, sir.
Okay, the two criteria should be there. So what happens in continuous? What is the usual variation? Whether it is more than 1 degree or less than 1 degree?
It is more than 1 degree, sir.
Is it touching the baseline?
No, without touching the baseline, sir.
Okay, what is intermittent?
It is more than 1 degree, which touches the baseline, sir.
Okay, what is remittent?
It is less than 1 degree, which does not touch the baseline, sir.
I think there is some amount of confusion with you. Okay, I will make clear this for you. Continuous, the change is not much. Okay.
Okay, sir.
And it is not touching the baseline also.
Okay, sir.
Okay, the change is also less than 1 degree Fahrenheit and it is not touching the baseline. Whereas remittent, the change is very high, that it is more than 1 degree Fahrenheit, but it is in between touching the baseline.
Okay, sir.
Where the majority of the fever in normal day-to-day life are the remittent fevers. Okay.
Okay, sir.
And intermittent is sorry. I also got confused here. Remittent is not touching the baseline, but day-to-day variation is more than 1 degree Celsius. Whereas
okay,
intermittent is touching the baseline, but variation is also more than 1 degree.
Okay. Yes.
Any fever eponyms, you know?
Eponymous
named
fever.
Fevers, some named fevers.
Yes, sir. Bell-Epstein fever is seen in Hodgkin's lymphoma, sir.
Okay.
And Saddleback fever is seen in dengue, sir.
Mm-hmm.
And Q fever because of Coxiella burnetii, sir.
Right. Okay, that's okay.
Go
for the next slide.
Yes.
Next slide. Okay, past history, there is no positive history in favor of anything or against this, right? So
Yes,
no
sir.
history of a contact with a patient with TB.
Yes,
Okay. Why did you ask a history of diabetes? Is it going to matter?
So because patients with diabetes are more prone to develop TB, sir. They are more prone because they are immunocompromised, sir.
Mm-hmm.
And they are more prone to develop TB, sir, if they have a contact with the patient of TB.
Okay. So actually this relation with tuberculosis and diabetes is both way. Do you know that? Even if a patient is not diabetic, after getting tuberculosis, there is a very high chance of the patient becoming over diabetic. Do you understand?
I don't know the underlying reasons, sir.
Hello?
So can you hear me, sir?
Yeah, I can hear you. Can you hear me?
Yes, sir. Yes, sir, I can
Yeah,
hear
see,
you, sir.
this relation between tuberculosis is actually in a both way. Okay.
Okay, okay, sir.
Many of you know that the patient of diabetes are more prone to have tuberculosis. Okay.
Yes, sir.
But it is also similar for the fact that patient of tuberculosis can also become diabetic if he is not diabetic priorly. Okay. That you
Okay,
should
sir.
know. Next slide. Okay, so she was a farmer, you told me, and she used to work in a paddy fields.
Yes, sir.
So this occupation is going to matter for the respiratory presentation.
So she could have a fungal infection because of actinomyces, sir, because she may develop farmer's lungs.
Yeah, that's right.
And since she is out in the open, she may have
any other than fungal infections. Any airway disease?
So there could be asthma, sir. Allergies may be present because of exposure to pollen or dust, sir.
Yeah, similar to asthma, there is one particular terminology.
Hypersensitive pneumonitis, sir.
Yeah. Hypersensitivity pneumonitis. Okay.
Yes, sir.
So, can you keep the differential diagnosis of hypersensitivity pneumonitis in your patient?
Yes, sir. Because she has a occupational correlation, and there is also since it is a airway involvement, there will be sputum production.
So, in your history of presenting illness or chief complaints, what was there as a suggestion of airway disease?
Sputum productions.
Okay, that was very scanty, right?
Yes, sir.
Then, what is a typical presentation or a symptom?
There will be associated V's may be present.
Yeah. That should be there to call it as a hypersensitive pneumonitis. Okay.
Okay, sir.
And to be as a chronic hypersensitive pneumonitis, although they can have fever, the wheezing should be the predominant symptom. That is missing in the patient. Okay.
Yes. Okay, sir.
And tell me some respiratory conditions which known to come on and off. Like they used to have exacerbations and reliefs.
COPD, sir.
Yeah.
Exacerbation of asthma.
Yeah.
And
again, just now we spoke about one terminology. Hypersensitivity pneumonitis can also have. Okay.
Okay. Yes.
A recurrent exposure to the same allergen.
Okay.
Can have acute episodes of hypersensitivity pneumonitis to the patient. Any other thing? Presenting as an intermittent exacerbations.
The rupture of any emphysematous bulla.
That is not the usual recurrent. Okay.
Okay.
COPD is okay. COPD itself is an acute exacerbation.
Okay.
Then ILD, the interstitial lung disease, majorly that is the IPF, idiopathic pulmonary fibrosis, can have acute exacerbations. Okay.
Okay, sir.
And bronchiectasis
Okay, sir.
can have the acute exacerbations due to superadded infections.
Okay, sir.
Okay, they can have acute exacerbations. So you should know the respiratory syndromes presenting as an acute exacerbations. Huh?
Okay, sir. Yes, sir.
Okay. Next slide. Okay. For the past, smoking. Oh, husband was a smoker.
Yes, sir.
So you should also ask the history of the indoor air pollution in this female patient who is presenting predominantly with cough and dyspnea.
Okay, sir.
One history that is missing is the indoor air pollution.
Okay, sir.
Especially in rural part of world, still now they are using this chula. Okay.
Yes, sir.
Due to inorganic dust, they are in fact the risk of developing COPD in this indoor air pollution is similar to the smoking in the male patients.
Okay, sir.
Okay, that should be there in your socioeconomic history that has been missing. Okay.
Okay, sir. Yes, sir.
And overcrowding, that should be mentioned because one of the differential diagnoses you kept as a tuberculosis.
Yes, sir.
That
Yes,
is missing.
okay.
And since your patient also has loss of appetite,
Yes, sir.
a short nutrition history also becomes important in this patient. Some examiners may have a tendency to ask the nutritional history.
Okay, sir.
Okay, a
Yes,
short history. Okay, maybe the last 24-hour diet she had. Okay, if
Okay,
at all you remember how to calculate the total calories also, that's well and good.
Okay, sir.
Okay, tell me some conditions of loss of weight without losing the appetite.
Thyrotoxicosis, sir.
Yeah, right.
Then diabetes, sir.
Yeah, right.
And
the parasitic infections, again, as I told you. Okay.
parasitic. Okay,
And pheochromocytoma.
Okay, sir.
Okay, so these are the 4 conditions which can have the normal appetite or in fact increased appetite with a
Okay, sir.
significant weight loss. Okay.
Okay, sir.
Okay, so then this history of smoking in the patient of his husband, can you tell me what is the meaning of former smoker?
Sir, sorry, sir.
Former smoker or current smoker. What do you mean by current smoker?
I don't know, sir.
Okay, what is heavy smoking? Do you know?
Smoking of more than 1 pack of cigarettes per day, sir.
Sure. Where you studied this? Okay, there is no strict definition for actually heavy smoking. Okay.
Okay.
But there is a definition for the former smoker.
Okay, sir.
Okay, and there is what is called as never smoker. I'm not throwing my own terminology. These are actually the terminologies given by CDC. Okay.
Okay.
See, the never smoker means the person who has smoked less than 100 cigarettes in his lifetime.
Okay.
Okay, am I clear?
Okay. Yes, sir.
A person in his lifetime, if he has smoked less than 100 cigarettes,
okay, sir.
Then he's called as never smoker.
Okay, sir.
So according to the CDC, you have permission to smoke 99 cigarettes.
Okay.
Okay, then the former smoker is the person who has smoked more than 100 cigarettes, but who
Okay,
has
sir.
left smoking since more than 1 year.
Okay, sir.
Okay, then the current smoker is person who has smoked more than 100 cigarettes.
Okay, sir.
And he's still continuing it.
Okay, sir.
Okay, that is what is called as current smoker. Am I clear? Okay.
Yes, sir. Yes, sir.
And then there are definitions like occasional smoker, daily smoker, etc. But these definitions you should know.
Okay, sir.
Okay, the next slide. Okay, this is You have summarized pretty well. Okay, this is a habit you should know. In fact, you should mention 3 to 4 differential diagnoses rather than mentioning a single diagnosis. Okay.
Okay, sir.
Because if you look at this presentation, it looks like you are searching for a system to examine before going into examination. That is not the purpose of taking history.
Okay, sir.
Okay, history of the purpose of history is to actually diagnose the condition.
Okay, sir.
Okay, examination is just to support the history.
Okay, sir.
It is not the examination which is going to give you the diagnosis. Keep in mind, it is the history which is going to give a diagnosis.
Okay, sir.
So, if you read this, this looks like you are taking the history just to go and examine which system. It is not like that. Okay.
Okay. Okay, sir.
So, you should mention the summary, then you should mention the chronic respiratory pathology is a very broad terminology. It can be anything. There are more than 100 diseases under chronic respiratory disease. Okay. So
Okay.
after mentioning the summary, you should mention the differential diagnosis. What is your first differential diagnosis? What is your second differential diagnosis? What is your third? Why you have kept this thing as first? Why you have kept this thing as second? That becomes important. Okay.
Right. Right.
And the art of this keeping diagnosis, differential diagnosis itself make you a good doctor. Okay.
Okay, sir.
For every particular disease, you need, for any particular presentation, you need to have 2 to 3 differential diagnoses at least.
Okay, sir.
Okay, let's go to the examination.
Yes. General physical examination. The patient's consent is obtained and she is in a well-lit room. The patient is conscious and oriented to time, place, and person. She is moderately built and poorly nourished. She has a BMI of 22 kg per meter square. She prefers to lie in the left lateral decipitous position. And there's no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. There are no external markers of TB, HIV, or any pulmonary malignancy. Vitals. She has a pulse rate of 84 beats per minute, which is full in volume, no specific character measured in the right radial artery. She has a respiratory rate of 26 cycles per minute, which is thoraco-abdominal in character. She has a blood pressure of 100 bar 70 millimeters of mercury taken in the right upper arm in supine position. The patient is febrile with a temperature of 100.8 degrees Fahrenheit. Systemic examination.
I think you need to stop here.
Yes, sir.
We will discuss the general physical examination.
Okay.
Okay. So, your patient, what are the positive points in the general physical examination?
She's poorly nourished, sir.
How do you say so?
Sorry, sir?
Why do you say so? Why do you think she's poorly nourished?
Because she has a BMI which is less, sir, for her age.
How much is her BMI?
22 kg per meter square, sir.
What is the normal BMI?
It is 21 to 24, sir.
Normal BMI is 21 to 24, no? What is the normal BMI? Normal BMI is 22 is a low.
She's towards the
I don't
lower.
think so. No, definitely not. Yeah, somebody has mentioned in the chat box. It is 18.5 to 24.5 is the normal BMI. Okay.
Okay. Okay.
In fact, for Asian people, for Southeast Asians, in which India is also included, it is only up to 22.5.
Okay.
It's about 22 to 22.5. We are labeled as overweight, the Indians.
Okay.
Okay.
Yes, sir.
So be careful when you mention some things, like you have mentioned BMI as 22 and you have mentioned that she is poorly nourished.
Okay.
Okay, so can it happen, like as BMI is normal, but can she be still poorly nourished? Is BMI a very good index of her healthy condition?
Not only BMI, sir, even the skin fold thickness can be checked.
Yeah. Okay.
Yes.
Then any other thicknesses? What is sarcopenia?
There is loss of musculature, sir.
Yeah. What is cachexia?
There is loss of body weight, sir, because decreased subcutaneous fat stores.
Okay. So I will give you two examples. Okay.
Okay, sir.
One person has a some chronic respiratory disease, be it a COPD or it is a tuberculosis, whatever it is. His
Okay,
BMI
sir.
is 25,
Okay, sir.
and there's one similar diagnosis patient whose BMI is 17.
Okay, sir.
Okay, one patient's BMI is 25, one person BMI is 17 with a similar pathology.
Okay, sir.
So, who do you think have a favorable outcome? A person with a BMI of 25 or a person with a BMI of 17?
No ideas.
Okay, it is the BMI of 25 person who is going to have better better outcome, because this is what is called as obesity paradox.
Okay, sir.
Okay, there are some conditions, especially these chronic respiratory conditions, in which obesity tries to confer some amount of protection.
Okay, sir.
Okay.
Yes, sir.
Any other paradoxes in the medical history you know of? Heard of
Pulses?
French paradox?
No, no.
Okay, French paradox is these French people, they tend to consume very high amount of saturated fats,
Okay, sir.
although their coronary artery disease risk is very low.
Okay, sir.
Okay, even though they consume very high amount of saturated fats, they have a very less risk for coronary artery disease. This is called as French paradox. You know why?
Okay.
What is the reason for that?
No, sir.
Because they consume a lot of red wine.
Okay,
Okay, which tries to protect from the development of this coronary atherosclerosis. That is what is
Okay.
called a French paradox. Okay, this some again even this question was asked in my MBBS final year exam. Okay,
Okay, sir.
so you can't expect how the question is going to come. So whenever you mention some things, mention properly. Otherwise, they will take the discussion in a completely different way, where you might not want to go the discussion. Okay.
Okay, sir.
Okay, so there is no parallel. So one positive history was the preferential position in the patient, that is left lateral decubitus
Yes.
in a patient. Okay, so you have mentioned that there is no external markers of TB, HIV, and pulmonary malignancy. Tell me about what the conditions which you looked for.
So in case of TB, we can look for flictanular keratoconjunctivitis in the eyes, sir.
Okay.
And there may be skin conditions like scrophulоderma or lupus vulgaris, sir.
Okay.
And in the neck, there may be sinuses or cold abscess may be present, sir.
Right. That should be the first thing you should mention.
Okay, sir.
Okay, rather than the skin and the eyes thing. Have you seen a patient of flictanular conjunctivitis?
No, sir.
Then how do you know whether it is a flictanular conjunctivitis?
There will be a solitary nodule will be present in the
Where it is situated?
in the near the limbus, sir.
Okay. 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 Have you seen a case of scrophulоderma?
No, sir.
Okay. Okay, you see sometimes actually have a habit of seeing in the internet, etc. Okay.
Okay, sir.
They are important. So one very important thing is look for evidence of tuberculosis in the lymph nodes, which are very common. Okay. Be it in the cervical region or axillary region. Okay.
Okay.
And look for sinuses in the atypical locations.
Okay.
Then some tubercular joint involvements. Okay. Tubercular arthritis, usually a chronic monoarthritis of the knee. Okay. Which is usually caused by tuberculosis, is also very common.
Okay.
Then HIV, what external markers you looked for?
There may be oral thrush in the mouth, sir.
Okay.
And patient may also have presence of Kaposi's sarcoma, sir. It's a red nodule.
End stage. Okay. Then.
And hairy leukoplakia may be present.
Okay. Then any other skin infection? Very common in HIV.
Molluscum contagiosum.
Not very common. Very common. The first and foremost thing is tinea. Okay. Especially the extensive tinea corporis, or also called as disseminated tinea corporis. Okay. So that has been can occur in HIV. In fact, very common. Okay. Then what you looked for the external markers of pulmonary malignancy?
Presence of clubbing, sir.
Yeah.
Hypertrophic osteoarthropathy, and there may be acanthosis nigricans, sir.
Okay.
And there may also be gynecomastia in such patients.
Yeah. Then any atypical neurological conditions, asymmetric neurological conditions, especially in right upper lobe malignancy?
Horner syndrome, sir.
Yeah. Okay.
Yes.
Then they can also have the atrophy of their hand, muscles in the hand, especially thenar and hypothenar eminence. Okay. Due to compression on the components of the brachial plexus by Pancoast tumor.
Yes.
Okay. They can also have a lymphedema similar to the breast carcinoma. Of the right hand, right upper limb. Okay. Any skin conditions, you know, the cutaneous markers of pulmonary malignancy?
Acanthosis nigricans, sir. Okay,
what is that?
There will be hyperpigmentation in intertriginous areas like the nape of the neck or under the armpits.
Okay, along with hyperpigmented, what is the typical description that is given for acanthosis nigricans?
Folding of the skin will be this.
It is hyperpigmented and velvety appearance. Okay. So other than pulmonary malignancy, what other conditions can have acanthosis nigricans? A very common condition nowadays.
Obesity.
Yeah, obesity, but better terminology is not all obese patients have. It is insulin resistance. Okay. What are the other manifestations of the insulin resistance you know of? What type of obesity? Central obesity or peripheral obesity?
Central obesity.
Yeah, central obesity, acanthosis nigricans, and skin tags. Okay. Especially if the number is more than 6. These 3 are the external markers of insulin resistance. Okay. This you should know of. These are very common. If at all you're sitting in an OPD, in a medicine OPD, when a diabetic patient comes, especially the type 2 diabetes comes, you can look for these signs to know the insulin resistance. Okay. Next, vitals. Okay. So, how many vitals are there? 4 or 5? What is the 5th vital that you're not mentioned in this case?
JVP.
No, JVP is not a vital.
Saturations.
Yeah. Okay, saturation is the 5th vital that is supposed to be mentioned nowadays in the case presentations. Okay. Especially in the post-COVID era. And another thing, sorry, I forgot to mention is the history of COVID that you're not asked in your patient. Okay. Can COVID presents like this long-standing fever, cough, dyspnea, which is progressing gradually?
No ideas.
Can it? No, it can present. Okay. It is called as long COVID syndrome. Where patient, after recovering from the acute illness, can have prolonged symptoms of this low-grade fever, dyspnea, cough, etc. Okay. Very rarely they can have pleural effusions, but it is definitely available. And the COVID vaccination should also be mentioned in the history. Okay. From now on, since we are in a post-COVID era, have a habit of mentioning the vaccination of for the COVID, whether received or not, especially
Okay.
presenting a respiratory case. Okay, because we don't know what is coming for us.
Yes. Okay.
Since COVID is only understood maybe 50 to 60% of the entire pathology, we might get to understand more and more in the long-standing case. Okay.
Okay. Sir.
So if at all your case taken this case in the post-COVID era, definitely mention the COVID vaccination and history of COVID. Okay.
Okay. Sir.
So what is the respiratory rate in your patient?
So it is increased 26 cycles per minute.
Okay, it is increased.
Yes, sir.
So is your patient in respiratory distress?
Only the rate of inspiration has increased, sir.
Okay, so what are the other signs of the respiratory distress which you should see?
There will be acidotic breathing will be there, sir.
What do you mean by acidotic breathing?
There will be a hyperventilation.
Again, the respiratory rate is increased, right?
Yes, sir.
Yeah. Other than respiratory rate, to know whether patient is in respiratory distress or not.
The depth
So one
of the
thing that you have missed in your vital.
saturation.
Yeah, you can see the saturation. Then any other thing?
The depth of the respiration.
That's okay. That's okay. Then you have mentioned, but you are not focusing on that. There is no cyanosis, right? Is cyanosis a sign of respiratory distress?
Yes, sir. Yes.
Yeah, cyanosis is not there. Then any other conditions? Any other signs of respiratory distress?
Use of accessory muscles, sir.
Yeah, that's very good. Okay.
Okay. Sir.
So you should mention that whenever your
Okay.
patient is in what you call the respiratory rate is 26, and you don't have a what you call equipment to measure saturation.
Okay, sir.
Just have a habit of looking for other signs. Use of accessory muscles of respiration. What are the accessory muscles of respiration? You look to know whether patient is in distress or not.
Ala nasal, sir. Then
Okay.
sternocleidomastoid.
Okay.
The abdominal muscles. Serratus
Okay.
anterior.
Okay.
Yes.
Okay. So you should mention that that you forgot to mention here. Huh?
Okay, sir.
Are there any use of any other signs, especially in children's?
Stridor may be present.
Okay. Next.
Uh,
Typical in children's. Chest indrawing.
okay, sir. Just in.
Okay, that especially the lower chest indrawing, although very rare in adults, but can be seen in elderly people.
Okay, sir.
Chest indrawing. Okay.
Okay, sir.
So the tachypnea, the low saturation, the cyanosis, the use of accessory muscles of respiration, and the chest indrawing.
Yes,
Okay.
sir.
Along with that, there are some objective things also, like the breath holding capacity.
Okay, sir.
Okay. You can ask the patient to count the number from 1 to 30 in one breath. Okay.
Okay, sir.
That is typically used to assess the respiratory function capacity, but can also be used to assess whenever there is an acute severe asthma is suspected, COPD is suspected. Okay, to know the breath holding capacity. Okay, so definitely whenever you are mentioned that your patient is in the tachypnea stage, you should have a habit of mentioning whether he is in respiratory distress or not. That becomes very, very important in this particular case. Okay.
Okay.
Especially in the background of blood pressure being 170.
Okay.
Okay. So you have mentioned that pulse is full in volume. What do you mean by full in volume?
The patient is not in any state of dehydration, sir.
Okay. So he's in volume overload condition?
No, sir.
So what do you mean by full?
I meant to state it to be a normal in volumes.
Yeah, use that term. Okay.
Okay.
So use normal in volume.
Okay.
Okay. Full in volume. Have you seen any textbook mentioning this word, full in volume?
No, sir.
No, isn't it?
Yes. Okay.
Okay. So what is the temperature in the patient? 108 degree Fahrenheit. Is it normal or it is high?
It is raised, sir. It is high.
It is high.
Yes.
So what is the normal relation between temperature and pulse?
So with every 1 degree increase in the temperature, there will be increase in the pulse by 10 beats.
Okay. Any name given for that? You know?
So it is called the Lieber-Mister rules.
Yeah, that's very good. So is this rule being followed in your patient?
I think so. Yes. Sir.
No?
Yes, sir.
Or yes? Yes.
Yes, sir.
So what is the normal body temperature?
It is 98.2 to 98.6 degrees Fahrenheit. Sir.
Okay, what is the normal pulse?
60 to 100 beats per minute. Sir.
Okay, so temperature has increased by how many degree Fahrenheit?
2 degree Fahrenheit.
Okay, so how much the pulse should have been increased to?
About 20 beats. Sir.
Okay, so considering you don't know the baseline, it should be at least close to 100 or 110.
Okay, sir.
Isn't it?
Yes, sir.
So, but it is not the case.
Okay, sir.
Pulse you have mentioned it is 84.
Yes, sir.
So, what is this condition called?
Relative bradycardia. Sir.
So, can we say that your patient have relative bradycardia?
It denotes to that only. Sir.
No, we cannot have. Can you say the reason? Can you tell me the reason why we cannot say your patient has relative bradycardia? We cannot say that your patient has relative bradycardia, definitely.
Don't know. Sir.
What are the criteria to what do you call it? Diagnose the relative bradycardia? Do you know?
No, sir.
Yeah,
no, sir.
just you can apply your mind. The one basic criteria is both pulse and temperature should be measured at the same time. Okay.
Yes. Okay. Sir.
You cannot measure temperature in the morning and you cannot measure pulse in the evening.
Okay, sir.
Okay, so I am considering that you have measured all these both things in the similar time.
Yes, sir.
The other very important criteria is the temperature should be at least above 102 to 103 degree Fahrenheit.
Okay, sir.
Okay. So this particular terminology of this relative bradycardia you can apply only when temperature is at least above 102, 103. 100.8 is actually just a mild rise in temperature.
Yes, sir.
Okay.
Okay, sir.
And another important criteria is patient should not be on beta blockers.
Okay, sir.
Am I clear?
Yes, sir.
The patient should not be on beta blocker. The temperature should be at least above 102. And the patient temperature and pulse being measured at the same particular time.
Yes, sir. Okay, sir.
So you should know that. Okay.
Yes.
So what are the causes of relative bradycardia?
Typhoid, sir. Enteric fever. I mean, then
both are same, na?
trench fever, sir.
What is trench fever?
Sir.
Tell me what is trench fever? What is a common condition which you see day-to-day life, which usually presents as the relative bradycardia, apart from enteric fever?
No ideas.
Okay, so I will give you the clue. Okay.
Okay, sir.
See, all these organisms which are intracellular.
Okay, sir.
Okay, can have this relative bradycardia. Okay.
Okay, sir.
So what are the intracellular organisms which causes fever? It is usually viruses, right?
Yes, sir. Virus.
So any viral fever can have the relative bradycardia.
Okay, sir.
I'm telling you can have. It is not a must thing. Any viral fever, be it a herpes infection, be it a dengue, chikungunya, HIV, all these can have the relative bradycardia. Okay.
Yes.
And among bacteria, tell me some intracellular bacteria.
Pneumococcus, sir.
Pneumococcus is an intracellular. No. Usually Mycoplasma, Legionella.
Okay, sir.
Okay, Chlamydia. All these infections can have relative bradycardia. Okay.
Okay, sir.
So this is the clue which you can remember. All the viral infections and intracellular bacteria like the Chlamydia, Mycoplasma,
Legionella.
and Legionella. Along with that, there is some enteric fever, although they are not intracellular. Enteric fever, all these can have the relative bradycardia. Okay.
Okay, sir.
And related to tachycardia, what some causes of related tachycardia?
I haven't heard.
Okay, so if there is myocarditis,
Okay, sir.
okay, any fever with myocarditis can have a very significantly increased heart rate,
Okay, sir.
irrespective of its temperature. Okay.
Yes, sir.
So similarly, these acute rheumatic fever,
Yes, sir.
again by causing myocarditis, it can have the related tachycardia. And diphtheria, again by causing myocarditis. So basic
Okay.
funda you should know rather than just by hearting the causes.
Okay,
Why
sir.
this is happening? Then only you will remember the things. Otherwise, it is very difficult to remember.
Okay, sir.
Okay, so the infections which can cause the myocarditis like diphtheria, acute rheumatic fever, all these can cause the related tachycardia. The bradycardia, the remembering point is intracellular organisms along with some bacteria like the enteric fever, etc. Okay.
Yes, sir.
Any other doubts from the general physical examination you want to know or you want to ask?
No, sir.
Okay, one have a habit of mentioning head to toe features in the general physical examination. Okay, since your
Okay,
patient is having loss of appetite, you should specifically look for any nutritional deficiencies in your patient.
Okay, sir.
Okay, they might be asked you you need to look for the vitamin deficiencies because this can definitely occur in a patient who is having loss of appetite, loss of weight, all these things. Okay, chronic inflammation.
Okay, sir.
Okay. Okay, so you can go for the examination.
Okay, sir. On systemic examination, on inspection of the upper respiratory tract, the nasal septum is in midline. There are no nasal polyps. Sinus is normal. No halitosis. Oral cavity is normal and tonsils are normal. Lower respiratory tract, the chest is normal in shape. Trachea is deviated to the right side. There is restricted chest wall movements on the left side. Fullness of left side intercostal spaces are seen. Apical impulse cannot be seen. No drooping of shoulders, supra or infraclavicular indrawing of fullness. There are no crowding of ribs. No scars or sinuses or dilated veins over the chest. The spine is normal and there is no prominence of the medial border of scapula. On palpation, the trachea is deviated to the right side. No intercostal tenderness. Apical impulse cannot be felt. The movements of the chest are decreased on the left side. Measurements, the anterior posterior diameter is 22 centimeters, whereas the transverse diameter is 32 centimeters with a ratio of 5.5:8. The total chest circumference at expiration is 82 centimeters, and on inspiration it is 85 centimeters, and the total chest expansion is 3 centimeters. The hemithoracic expansion on the right side, at expiration it is 40 centimeters, on inspiration it is 43 centimeters, whereas on the left side, at expiration it is 40 centimeters, on inspiration it is 41 centimeters. Therefore, the left hemithorax expands lesser than the right hemithorax. Vocal fremitus, the right side chest is normal, whereas on the left side, the mammary, axillary, infraaxillary, suprascapular, and the interscapular and infrascapular vocal fremitus is absent in these areas. On percussion, the right side of the chest is normal, whereas on the left side, the mammary, axillary, infraaxillary, suprascapular, interscapular, and infrascapular stony dull note of percussion is felt, sir. On tidal percussion, there is no dullness on the right side. Liver dullness can be felt on the right side fifth intercostal space, and the liver span is about 14 centimeters. On trop space percussion, a dull note can be felt. On auscultation, on the right side, there are no normal vesicular breath sounds are heard, whereas on the left side, In the mammary, axillary, infraaxillary, suprascapular, interscapular, and infrascapular, the vesicular breath sounds are either absent or reduced, sir, and there are no added sounds on either right or left sides. And vocal resonance, the right side of the chest is normal, whereas on the left side, mammary, axillary, infraaxillary, suprascapular, interscapular, infrascapular vocal resonance is absent. Other systemic examination, cardiovascular system, S1 and S2 is heard, sir. No murmurs were heard. Per abdominal examination, there is soft and non-tender abdomen, no organomegaly. On central nervous system examination, there is no focal neurological deficits.
Okay, what are the positive points in the examination?
So on inspection, there is reduced apical impulse is not seen, sir. Trachea is
Take the
deviated.
slides back. So what are the causes of the apical impulse being not visible?
Physiologically, in patients with obesity, sir, and especially in females, it is difficult to see the apex.
Right.
And if the apex is behind the ribs, sir.
Right.
And pathologically, it can be due to a pneumothorax or a pleural effusion, sir, or a thickened.
Why it becomes non-visible?
Because the chest, because the lungs which are hyperinflated in the pneumothorax, it will cover over
lungs
the.
Are hyperinflated in pneumothorax.
Sorry, sir, it is hyperinflated in COPD because of increased chest lung expansion. It will cover the apex, sir.
No, I asked you pneumothorax. You told me in pneumothorax and in pleural effusion it is not seen.
Yes, sir. It will be shifted to the opposite side, sir.
Okay. Any other positive points on the inspection?
There is fullness of the intercostal spaces, sir.
Where?
On the left side, sir.
Okay. And all the areas?
No, sir. In the mammary, axillary, infraaxillary, and on the back.
What does it suggest? Fullness?
Fullness suggests probably a pneumothorax or a pleural effusion, sir.
Okay. Then any other things which can be suggested in the presence of fullness?
It can be empyema, sir, if there is associated tenderness or pains.
Yeah. Okay. Any other positive point in the examination?
No, sir.
No, you told trachea is deviated to the right side.
Yes, deviated. Yes, sir. Trachea is deviated.
Okay.
Yes, sir.
So what does it suggest?
Since the trachea is deviated to the right side, we can expect, and there is restricted chest wall movements on the left side, we can expect left-sided pathology, sir.
Okay, left-sided volume reduction pathology?
No, sir. In volume reduction, there will be a shift to the same side, sir.
Okay, so in case of volume increase, either in the pleural space, some accumulation of fluid or gas, so it is usually shifted to the opposite side.
Yes.
So did you look for any sign of this tracheal deviation?
Trail sign, sir.
Yeah.
It is positive.
What is that?
It is undue prominence of the clavicular head of the sternocleidomastoid mastoid, sir.
Okay. So is it possible to trachea being central in the presence of pleural effusion?
Yes, sir.
Okay.
If it is smaller, less in amounts of the pleural effusion.
Okay.
Or there is bilateral pleural effusion may also cause a central.
Correct.
Yes, sir.
Correct. Then any other cause?
If the pleural effusion is due to a malignancy, underlying malignancy, sir, the endocarcinoma due to a absorption collapse, it can keep the trachea in size.
Okay, any endobronchial growth?
Yes, sir.
Not only malignancy, even tuberculosis. Patient can have the lymph nodes which is compressing on the bronchus. Simultaneously, patient can have extrapulmonary in the pleural space. Okay. So any endobronchial growth, the collapse and effusion on the same side, the trachea can be central. Okay.
Yes.
So what are the positive points in the palpation?
On palpation, we can, the apical impulse cannot be felt, sir, and movement of the chest on the left side are decreased.
Okay, when do you say that the apical impulse is not felt?
So I didn't get the question, sir.
When do you say that apical impulse is not felt?
When the thrust out, the most maximum outward thrust cannot be felt on palpations in the left fifth intercostal space.
In what position? Suppose you have lied down the patient and you have kept a hand and you are looking for apical impulse. Apical impulse is not felt. Okay.
Yes.
So can you just straight away consider that apical impulse is not felt?
Patient should be in sitting position, sir.
No. After in supine position, patient should lie on left lateral position.
Okay.
Okay. Even in the left lateral position, if apical impulse is not felt,
okay,
then only you should consider that apical impulse is not felt. Okay.
Okay.
So these are all standard definitions. This is not my created thing. Okay.
Okay.
So to consider apical impulse is not felt, you should first examine in the supine position, then in the left lateral position. Okay.
Yes.
Okay. Then any other positive findings?
So the left hemithoracic
just movements are very, very important, right? So you consider that it is a decreased on left side. Okay.
Yes. Yes.
So in all the lung fields.
Yes, sir.
Okay. So any other positive points? So what does the measurements add on?
The total chest expansion is normal, sir, which is normal 3 to 5 centimeters is normal. Whereas hemithoracic expansion is lesser than that of the right, sir.
Okay, so left side it is lesser.
Yes,
the total chest expansion is okay.
Yes. Sir.
Tell me one condition without any involving the respiratory system, the chest expansion is reduced.
Ankylosing spondylitis.
Okay, that's good. So the diameter of right hemithorax was more than left hemithorax.
On inspiration, sir, it was inflated.
Okay, it was the expansion. Okay.
Yes.
So what was the diameter?
43 on inspiration. 43 centimeters on inspiration, sir.
Okay. No, just a diameter, just a measurement of hemithorax.
40 centimeters on both sides.
Okay, so it is equal.
Yes, sir.
What should be there in presence of the pleural effusion?
Usually, since there is fullness, the left side should have been increased. Sir.
Increased. So it is same. Okay. So that you should mention. Okay. Not you have mentioned only expansion. You should also mention the hemithorax circumference. Huh?
Okay.
Okay. And then next slide. The distance you have not mentioned, the spinoscapular distance.
No, that I have not mentioned. I forgot to mention.
Okay, that you should mention. Okay.
Okay. Sir.
That would have yield a positive point. Okay. Next, what is this?
Vocal fremitus, sir.
What is vocal fremitus?
So it is the vibrations which are produced in the vocal cords and in the larynx, which are passed through the tracheobronchial tree, sir.
So this is a vocal fremitus or a tactile fremitus which you have tested for? Or both are same?
Tested for vocal fremitus.
Okay. By palpation?
Yes.
Okay. So which side of the hand you are using for the vocal fremitus testing?
The back of the palm, sir.
Back of the palm?
I mean the
dorsal aspect.
Ulnar border of the palm is used.
Yeah, ulnar border of the palm. Okay. So how do you test for the vocal fremitus in palpation? Can you elaborate?
Yes, sir. We have to ask the patient to say 111 or 99 continuously, and we have to palpate each area on both sides simultaneously, sir.
How? One hand being kept on the right infraclavicular, one hand kept on the left infraclavicular.
Yes, sir. Simultaneously, sir. One after the other.
Where it is mentioned? Is both of your hands have a similar sensitivity for the touch?
No, sir.
No, then how can you infer the same amount of vibration felt when your sensitivity is only different with both the hands?
So we have to use only one hand, sir. And
then
with that,
you told me that it is simultaneously, right?
no, sir. With one hand, one after the other, we have to look for the
sequential corresponding areas. Okay.
Yes. Okay, sir.
So you should mention properly.
Okay, sir.
Why do you want the patient to say that 111 or 99?
So it produces uniform vibrations throughout the tracheobronchial.
Are you sure?
No.
No. Huh? Have you read about this? Why this particular 99 was told to the patient to tell?
I can't recollect, sir.
Okay, so actually this particular thing was first when they discovered, it is not the English literature, it is either German. I don't actually recover the knowledge. The original word which they used to produce the vibration of the larynx was the diphthong of 99 in their language. Okay, so diphthong means any word which contains two vowels one by side. Okay, for example, balloon, it has got double O.
Okay, sir.
Isn't it? So two vowels should be there in a continuous pattern in one single word. 99 does not have. What is the 99 spelling? N-I-N-E-T-Y.
Yes, sir.
Okay, and N-I-N-E. So the two vowels are not coming sequentially here.
Okay, sir.
So they just took a direct transformation of this 99 in their language to 99 in English. Okay. So that is actually not the right word.
Okay, sir.
There are actually different words given. The words given are the O boy. Okay. You can use O boy because boy has O and Y. Both are vowels which are coming continuously.
Okay, sir.
You can have toy boat.
Okay, sir.
You can have balloons, preferably blue balloons. Okay, which has got U and E and double O.
Okay, sir.
You can also have Scooby-Doo. Scooby-Doo can help. Okay, it has got double O.
Okay, sir.
Okay, so you should use preferably the words which are having the two vowels continuously.
Okay, sir.
Okay, so this is very, very important. You should practice these things. Okay, some things have come, what you call, without any sophistication in the literature. They have just come from one textbook to another. Somebody writes a textbook by seeing one textbook.
Yes, sir.
Okay, so some of the examiners might know these things. Even if examiner doesn't ask you in exams, you should know these things, especially if you are interested in internal medicine. Okay.
Okay, sir.
Okay, next slide. Okay, percussion. Okay, it was stony dull in almost all the left-sided lung fields except supraclavicular and infraclavicular.
Yes.
What do you mean by stony dullness?
Stony dullness, while percussing the patient's pleximeter finger will
Patient's pleximeter finger.
Sorry, sir. The examiner's pleximeter finger will experience some form of resistance, sir. Okay,
so have you experienced that resistance?
In that patient, it was difficult to percuss, sir.
Why? So female. Because she was a female or what?
She was a female, yes.
So I was asking why you felt difficulty in percussion.
Usually the percussion note which I get in, which I do and get, it was not as easy in doing that patient.
Okay. So make a habit of doing percussion. Okay. You should learn how to percuss and never forget a stony dullness. You actually percuss a stony dullness. Huh? It is just as good as percussing over a stone.
Okay.
Huh? So just try and see on percussing directly on a stone. Then you will experience what is stony dullness.
Okay, sir.
Tell me the notes of this, what you call percussion in their order.
Okay, sir. A normal lung will be resonant on percussion, sir.
No, I am asking in order, not only lung. Okay.
Okay,
In
sir.
order of their dullness.
Okay, sir. First will be a tympanic note, sir.
Okay, where do you see that normally?
Normally it is seen in the abdomen, sir, because of hollow viscous organs, sir.
Right. Okay.
Then it will resonant note will be heard over a normal lung, sir.
Mm-hmm.
And then impaired note is heard when there is some kind of pleural thickening or fibrosis or collapse of the lungs, sir.
Mm-hmm.
Woody dullness is heard is elicited in case of a consolidations and pneumonic consolidation,
Mm-hmm.
and dullness in cases of pleural effusions.
Okay. So I have also got a confusion whether the terminology of woody dullness actually exists or not. Okay.
Okay.
Till now I couldn't find out the answers, because even some of the examiners are get very irritated when they hear the terminology called woody dullness. Okay.
Okay, sir.
So it is depends on the examiner what they want. But the woody dullness terminology is being mentioned only in some textbooks. Okay. So it is not a good terminology to use. So, but stony dullness, yes, for pleural effusion, the one and only cause for stony dullness is pleural effusion. This can be the terminology which we can use. But woody dullness, I'm not sure. Okay.
Yes.
Okay. So tidal percussion, no dullness. What does this mean?
When we percuss from the second intercostal space till the fifth intercostal space, and we feel a liver dullness on the fifth intercostal space, and we ask the to take a deep inspiration, and if the resonant note occurs, then it means diaphragm has pushed down, and we can elicit a resonant note, sir. So it is tidal percussion is basically to differentiate between a measure of diaphragmatic exertion. It is used to differentiate between a supradiaphragmatic and an infradiaphragmatic pathology, sir.
Okay, tell me, name some infradiaphragmatic pathologies.
Subphrenic abscess, sir.
Okay.
Amoebic liver abscess.
Common hepatomegaly, simple hepatomegaly, right?
Okay, sir.
Okay. So drop space dull note. What is drop space?
Sir, it is a crescentic space in the left chest, sir. It is superiorly bound. Its superior boundary is the left sixth rib, inferiorly by the left subcostal margin, and the lateral is bounded by the left mid-axillary line, sir. The normal content is fundus of the stomach, sir.
Okay. So next slide. Okay, so this is of the breath sounds. Okay. So breath sounds were absent in some lung fields and reduced in suprascapular and axillary. They were reduced, whereas in others they were significantly absent.
Yes, sir.
And there were no added sounds.
No added sounds.
Okay, what are the added sounds you know of?
Bronchial breath sounds like tubular breath sounds, cavernous and amphoric, sir.
Are there added sounds?
Sorry, sir. There are bronchial breath sounds, sir. Added sounds, bronchophony.
No.
And
what are added sounds?
Sorry, sir. Crepitations.
Yeah.
Rails. Rhonchi, sir.
Crepitations and rails are same.
And rhonchi, sir.
Crepitations, rhonchi, and what do you get in this pleuritis? Pleural rub.
Pleural rub. Okay. Yes.
Okay. So the breath sounds are vesicular and bronchial. The added sounds are the crepitations or more preferably crackles.
Okay.
Or rhonchi or pleural rub. Okay.
Okay.
And the one thing which you forgot to mention here is the voice sounds. Okay. What are the voice sounds? Where you ask the patient to make some voice and then you auscultate.
Yes, sir. They are whispering pectoraloquy, egophony, sir,
Okay, right. Another one.
bronchophony. Sir.
Yeah. Okay. So in auscultation of respiratory things, three things you should mention. One is breath sounds, the added sounds, and voice sounds. Okay.
Okay, sir.
Okay. So voice sounds, among voice sounds, you have got bronchophony, egophony, and whispering pectoraloquy.
Okay, sir.
Okay. So what would be the voice sounds in your patient?
My patient may have egophony, sir.
Why? What is egophony?
There will be a nasal intonation to the sound which the patient makes, sir. Wherein if we ask the patient to say A, we can hear the word as E, sir, on auscultation.
E. Okay, again, it is not E. Okay.
Okay, sir.
It is A and E. It is A. It is like a goat.
Okay, sir.
Okay. Egophony is also called as bleating of a goat.
Bleating of a goat. Yes, sir.
Okay. So it is like a the goat saying A, isn't it? It is not A. It is E, like A and E combination.
Okay.
It's also called A to E transformation.
Okay, sir.
Okay. So what is whispering pectoraloquy?
When we ask the patient to whisper something on auscultation above the level of pleural effusion, we may hear it very distinctly, sir, on auscultation.
Okay, only above the level of pleural effusion.
Or in consolidations.
Yeah. Okay. So why in your patient you haven't looked for this whispering pectoraloquy above the level of pleural effusion?
So because the level of effusion is still the mammary area, sir. So, so it could be a pleural effusion, sir.
What? It could be a pleural effusion. No. What I'm asking is,
yes, sir.
Above the level of upper border of pleural effusion, you might get some of the features suggestive of consolidation. You might get bronchial breathing, you might get bronchophony, you might get impaired note, you might get the whispering pectoraloquy. All this because of the underlying consolidation, isn't it? Where the airway is patent, it behaves like a collapsed patent airway.
Yes.
Which is similar to consolidation in all the examination findings. Okay. So in your case, you haven't mentioned all those findings. Okay. You haven't got the upper level of dullness or what? Because in percussion, you have definitely got the upper level of dullness.
Yes, sir.
It is in the memory, isn't it? Have a habit of mentioning the intercostal spaces also, especially in cases like these.
Okay, sir.
What is massive pleural effusion?
Massive pleural effusion is when the level of dullness is still the second intercostal space.
Yeah. Okay. If definitely in your case, if it is mentioned, if it is coming till second intercostal space, then your patient becomes a case of massive pleural effusion. Okay.
Yes, sir.
So you should mention the intercostal space also.
Okay, sir.
There is no wrong in mentioning that thing. If at all somebody is asking why you have mentioned intercostal space specifically, then you can mention this criteria.
Okay, sir.
Any other signs which you can elicit in a patient of massive pleural effusion?
Mediastinal shift can be there. And
okay, let me ask you the direct questions. Okay, what is Broca's triangle?
Okay, sir. So in the due to posterior mediastinal shift, we draw an imaginary line from the upper level of the effusion to the 10th dorsal vertebra, and we draw an imaginary line from the 10th dorsal vertebra to along the lower limit of the lung resonance, and joining both of them will form the lateral boundary. And if there is any depth there, we can say there has been a posterior mediastinal shift.
What do you say? If you what will be there in that place?
Resonance, sir.
Okay, there will be a resonant note.
Yes, sir.
Okay, so you forgot to mention that also. Okay, whether specifically you look for that sign. Okay, those are some fancy signs you should look for.
Okay, sir.
Okay, what is Garland's triangle?
I don't know, sir.
Okay, this is a homework. Okay.
Yes, sir.
Okay, Garland's triangle is a homework, and Broca's triangle you are told. Okay. Okay, so in auscultation, I have a habit of mentioning voice sounds.
Okay, sir.
Okay, so coming to the next slide. In CVS, again, you should mention, sorry,
Vocal
okay, same, these findings are confirmed, right?
Yes, sir.
Okay, so in CVS, you should mention the positive findings, if at all they're positive, like the apex beat is not been palpable.
Okay, sir.
Okay, again, you should mention there is nothing wrong.
Okay, sir.
Okay. So what do you expect in a patient of massive pleural effusion for the heart sounds to become?
They will be muffled, sir.
Then are they muffled? Were they muffled in your case?
I
Or you
couldn't
can hear them distinctly,
No, sir. I
properly?
couldn't hear them properly.
Okay, so you should mention that if at all they are there. Okay, you know how to explain, so you need not fear to
Okay,
write
sir.
the positive findings. Huh?
Yes, sir.
Okay, so there was no organomegaly. So what would have happened if there is splenomegaly in this case?
We could have suspected a lymphoma, sir, or a leukemia.
Right.
Could have caused a massive splenomegaly.
Okay. So what is the final diagnosis?
This is my summary, sir. My final diagnosis is it is a case of left-sided massive pleural effusion, probably of tuberculous etiology without any complications.
What complications you looked for? Okay, another thing you should mention is whether in respiratory distress or not, because your diagnosis is massive pleural effusion.
Yes, sir.
Okay. In cardiovascular case, you will be mentioning whether in heart failure, in sinus rhythm or not, isn't it?
Yes, sir.
In respiratory case, especially in a case of this massive pleural effusion, you should mention whether he is in distress or not, because first thing you see when a patient of massive pleural effusion is to relieve his what you call the respiratory difficulty.
Okay, sir.
So why do you say without any complications?
So
What are
because
complications you looked for?
there is no development of empyema thoracis, sir, or there is no collapse of the associated collapse of the lungs, sir. And there is no thickening of the pleura.
Okay, I would say it is a case of hydropneumothorax.
So in case of hydropneumothorax, we'll get a straight line dullness, whereas in a pleural effusion, it is difficult to elicit a straight line in the upper border of the pleural effusion.
Okay, then any other typical history, or typical examination finding?
There will be shifting dullness.
Yeah, that you have not mentioned.
Yes, sir.
Okay.
Okay, sir.
That should be mentioned.
Okay, sir.
So this is a case of left-sided massive pleural effusion, probably of tuberculosis. Why tuberculosis?
So because there is a So because there is a evening low-grade continuous fever with the evening rise of temperature, and there is loss of appetite with loss of weight. And
still, you want to consider any other malignancies? Sorry, any other causes like malignancies?
No, sir.
No, you have definitely ruled out the malignancy in your patient?
Because I have ruled out by asking if there is any history of hoarseness of voice or difficulty in swallowing, like dysphagia.
So if there is no dysphagia or hoarseness of voice, then malignancy is ruled out?
No, sir, not completely.
So it is definitely difficult to completely rule out the malignancy in the patient, okay, considering the age and history of significant weight loss, okay?
Yes, okay.
So still, it should be the diagnosis. Preferably, you should tell it as a case of left-sided massive pleural effusion.
Okay, sir.
Without any complications, not in respiratory distress, probably of tuberculosis etiology, but still I would like to consider the malignancy in this patient.
Okay.
Okay.
Yes, sir.
Okay. So any doubts you want to ask?
Yes, sir. I have one doubt, sir.
Okay.
So in case of pleural effusion, we say that there is a cardiac resonance above the level of pleural effusion because of compensatory emphysema, sir. So what is compensatory emphysema, sir, and how does it develop?
See, this cardiac resonance in above the level of pleural effusion, sometimes what happens if the patent airway is there?
Okay.
Okay. Above the level of the pleural effusion, whatever the part of the lung that has been collapsed.
Yes, sir.
Okay. Sometimes try to act in an overway. For example, this lung parenchyma is completely normal. Your airway is normal. Just it is being pushed by the underlying fluid.
Yes, sir.
Okay. But this is not a common finding. It is usually the upper border of the pleural effusion usually have a collapse, because the tuberculosis, which usually occurs in a case of the pleural as an extrapulmonary tuberculosis, this usually occurs as a secondary thing. It is not usually a primary thing. There is usually some amount of the parenchymal involvement also.
Okay.
Especially the lobe just above the level of pleural effusion. So it is usually not seen in a case of tubercular pleural effusion, this cardiac resonance.
Okay.
It is seen when the cause is something else.
Okay, sir.
Okay, when the underlying your lung parenchyma is completely normal, it can take part in the air exchange. So it just trying to act in a more compensated way.
Okay, sir.
That is why cardiac resonance can occur in this patient, although it is not what you call predominant finding.
Okay.
Okay, nowadays the terminology is not definitely being followed.
Okay, sir.
Okay, it can occur in a case of the some cavity also, although even in the absence of pleural effusions, cardiac resonance can occur in the cavity also.
Okay.
So, but above the level of pleural effusions, cardiac resonance concept is there. Nowadays, it is getting obsolete. Okay.
Okay. Okay.
So, any other questions?
None from my side.
Okay. Okay. It's a nice presentation, Aakash. I think it's pretty well. Okay.
Thank you, sir.
I compare myself as an intern in last 6 years. You are much better. Okay.
Thank you, sir.
I didn't know whatever the knowledge you have at this level. Okay. Keep studying and all the best for your all the things. Okay.
Thank you so much. Thank you, sir.